Okay, it's being recorded. And Dee Dee is going to stream on Facebook. Hello, everyone, as you all are joining us. We had a chaotic start to today's webinar as we have had a technical issues with Zoom. We apologize for that chaos. We are currently trying to get everything set up as we get started. So y'all just come on in, take a seat. And of course, this would be a super dramatic moment for us to get this conversation started. My name is Jenny Castillo, and I am the Regional Engagement Director for the Southern Economic Advancement Project. As we have set up a series called Diving into Debt, we had a great conversation about student loan debt last a couple of weeks ago, and now we're having the conversation about Medicaid unwinding and medical debt. So we are excited to have our panelists online with us. As we get things settled and we're going to start streaming, I'm going to send an email to our other participants to get them to join us again. And apologies for all the technical issues here. Technically, this was not my fault. So Zoom is having some issues. We are back on. Please use the link to join us. All right. Thank you so much for your patience as we get this started. And we also just want to see if our other panelist, Eva, is going to be able to join us now that there's been a little bit of a push here, but let me see, they could be in attendees. So 1 second. Okay, there's Eva. And now let me just try to get Sarah Beth Gale, our executive director, in as well. All right, Eva, thank you for being here. Okay, now we can breathe. Everything looks like Zoom was just zooming as Zoom does. So thank you all again. Once more, apologies for the chaos here. Dee Dee Dunham is on our line as well, and Dee Dee is going to stream to Facebook. So once you see that stream, we'll be able to go ahead and get going on that. But we are going to get started as this is being recorded, so we're able to use this information later and share. Hello again, all. My name is Jenny, and as I mentioned earlier, I am the Regional Engagement Director for the Southern Economic Advancement Project, also known as SEAP. We would like to welcome you to SEAP's Diving into Debt series, Medicaid Unwinding. In March 2020, the Families First Coronavirus Response Act, FFCRA, temporarily waived certain Medicaid eligibility requirements. The easing of these regulations helped ensure that millions of Medicaid recipients would not lose their health care during the pandemic. However, states will soon be required to restart Medicaid eligibility reviews. This Medicaid unwinding, as it's being called, will drastically impact millions of families in the South. In collaborations with the Centers for Medicaid and Medicare and Medicaid Services and RIP Medical Debt, today we will provide critical updates and resources for advocates like yourself to share with your community. To get us started, I would like to welcome SEAP's Executive Director, Sarah Beth Gale, to discuss the Georgia and North Carolina findings from our survey that we did earlier this summer with Perry Undham. Sarah Beth, I'm going to share the screen for you.
Great. Thanks so much, Jenny. And Sarah Beth Gale, Executive Director of the Southern Economic Advancement Project, or SEAP. We're really excited to have this conversation today. Thank you, everyone, for being here. Thank you for being patient with us. Definitely not Jenny's fault. It was a worldwide Zoom outage. So appreciate your patience with us. And I just wanted to kind of set the table for this conversation about why this is such an important conversation, particularly for the South to have. And so I'm going to share my screen and just do a couple of slides. Let's see if I can click on this. Looking good, Jenny? Okay, great. So we have been partnering with Fair Count and National Conference of Citizenship on Pandemic to Prosperity South, a quarterly report that looks at indicators across a number of issues, including health. And the most recent report came out 2 weeks ago. And so just wanted to highlight a couple of health-related indicators to kind of show the conditions in the South and why this is so important. So really to start out with the ultimate health indicator of life expectancy, we can see that Mississippians have the shortest life expectancy among all Americans, almost 9 years lower than Hawaii, the longest life expectancy state. The next 6 worst life expectancies are all Southern states. When we think about, I can move to the next slide, maternal mortality as well, pregnancy-related deaths. Again, the South is the worst in the nation, particularly in Mississippi, Tennessee, Louisiana, Alabama, Arkansas, and Kentucky, having rates that are 66% higher than the rest of the nation and really than the rest of the developed world. Anxiety and depression, these are both worse in the South and worse than pre-pandemic. We're up threefold from where we were in 2019 this fall for folks reporting symptoms of anxiety and depression. This is particularly an issue in, again, Mississippi, Louisiana, Alabama, and Arkansas, some of those states where it's almost 1 in 2 adults reporting symptoms. These are longstanding conditions. One of the newer one is long COVID. So again, Southerners lead the nation in suffering from long COVID symptoms. 32% of adults in the South who have had COVID report having long COVID symptoms compared to 29% of non-Southerners. And from places like West Virginia, that's almost 1 in 2 COVID survivors who are experiencing long COVID. And so we know that part of these health conditions that we experience in the South are policy choices, such as not expanding Medicaid in most Southern states. And we know also that Southerners want change. We did a poll, as Jenny mentioned, in North Carolina and Georgia in particular this summer to ask questions about values and priorities around health. And I'm going to throw the North Carolina ones up here, but the Georgia are extremely similar to this. And that, 7 in 10 North Carolina residents said they're worried about the cost of health care in the first half of 2022. And that holds across race, across age and gender, geography, and partisan divides, that there's this worry about the cost of health care. And there's universal prioritization of health insurance, knowing that health insurance is important to have and that there are barriers to it. So about 7 in 10 cite health insurance is unaffordable if you lose your job or if you have some new health condition arise and you have to go seek your own health care. And finally, this is a shared value that folks should have affordable health care. So almost 9 in 10, again, this is North Carolina, but it held for Georgia as well, believe that residents should have an affordable option for health care, that it should be not just for physical well-being, but also mental well-being and financial security, and that the result will be a healthier and more productive workforce. This holds across race, it holds across partisan divide, that these are shared values here in the South. And so we're really excited to have this conversation today with RIP Medical Debt and with CMS, because we know there's important changes coming along the way. And the South is not always the leader in helping folks navigate those changes. And so it's really important that you're here on the line today, whether you're a nonprofit or advocate, whether you're a mayor or city council person, whether you work for a foundation or you're a legislator, because you're going to have important conversations, important connections in your community, and can be a really important linkage and source of outreach, communication, and navigation as these changes occur. So thank you so much for being here. I'm going to turn it back over to Jenny and just really look forward to the conversation.
Thank you so much, Sarah Beth. We really appreciate this insight. And we will have that information available to you all after the webinar as well. Now we'd like to welcome Eva Marie Stahl. Eva is the VP of Public Policy at RIP Medical Debt. Eva oversees the development and implementation of RIP Medical Debt's policy work. She works closely with RIP's staff to ensure that beneficiaries' voices and experiences are centered on solutions that address the medical debt crisis. Before RIP, Eva was a leader in the health advocacy community for over a decade as Director of Policy and Partnerships at Community Catalyst. Eva will have to jump off immediately after her presentation, but any questions you have, we can forward to her and provide insight after the webinar. Thank you, Eva, for being here.
Thanks for having me. And Jenny, are you going to pull the slides for me or should I pull them up on my own?
You can pull them up on your own.
Okay. give me just a second to figure out how to sort of share my screen here.
At the bottom, it says share screen, and it will allow you to do it your whole screen or just portion.
Got it. All right. Thanks for your patience, everyone. Okay, hopefully everybody can see that.
Yes, we can. It's saying
From
has started
beginning.
sharing screen. There you
There we go. All right. Technology able. All right. Thanks for having me. I'm really excited to be here. As Jenny said, I work at RIP Medical Debt. Just for those of you that don't know about us, we buy medical debt in bulk and we abolish it for individuals, getting rid of it entirely with no tax burden. And I'll talk a little bit about that. So I'm going to just talk a little bit about medical debt and how pervasive it is, give you a little bit of context, talk a little bit about our model and how we abolish debt, but how it's only one part of what needs to happen, and take a look at some of the bigger policy agenda items that we focus on and some of the things that you can do anywhere from the local to the federal level. So I think that it's pretty clear to people that medical debt is pretty pervasive, right? It's affecting everyone, everywhere. Kaiser Family Foundation has noted that there is at least, it's probably more, $195 billion worth of medical debt that's being carried by individuals across the country. And that affects over 100 million people who are struggling with this medical debt, creating despair and hardship for them. These numbers in the gray background are just sort of a snapshot of some of the medical debt bills that we've abolished in the past couple of months. And as you know, there are deep inequities in the South, right? That the mean stock of medical debt is higher in those dark red areas, which are mostly in the South. And we know that that is linked to not expanding Medicaid. Here's just an image for you. I actually ran the numbers for the states listed in on this slide so that you could get a sense of at least some of the work we've done to date, but also you can see the disparity in how much debt is being carried. So for us at RIP Medical Debt, we've helped over 1 million people in these states, these constituents, and paid off over $2.2 billion in medical debt. But if you look at the distribution of medical debt by region, the South clearly is carrying more medical debt than other states. Relative, at least to the North, a quarter of people are carrying medical debt, as opposed to just a little over 10% of individuals in the Northeast. And I really encourage you to explore medical debt in your community. The Urban Institute has put together data that's really generated from credit reports. So it's only a sample of medical debt, but it still really showcases the deep disparity of medical debt. And you can look at the county level with this tool and play around with it, but you can really see sort of the wide disparity between white communities and communities of color. I actually chose Knox County because if you follow the Kaiser Family Foundation's series of pieces on in their sort of their media outlet around medical debt, there was actually a piece last week on Knoxville and looking specifically at sort of the structural inequity of medical debt and how it really deeply affects Black households. And medical debt really leaves people with a lot of financial problems over the short term and the long run, right? Many use all of their savings to pay their medical bills. It hurts their credit rating. Sometimes they will shift these bills onto credit cards, so it is no longer medical debt, but then becomes credit card debt. They often are making trade-offs around food and housing to pay their medical bills, delaying education plans to buy a home, and many people declare bankruptcy. But most importantly, medical debt's bad for your health, right? We know that people, when they have medical debt or they're fearful about the cost of medical care, that they don't seek care. And we know that it increases the odds of food and housing insecurity. And most importantly, I can tell you from the thousands of letters and stories that we receive that health debt really creates tremendous stress and leads to mental health issues, increased likelihood of substance use, and just causes sort of emotional trauma for people. And I've highlighted one of these stories from the stories that we collect from someone in Georgia that really talks about the burden of being diagnosed with cancer, needing to seek out treatment, and knowing that they had to accrue the medical debt in order to live. But the deep sort of despair and awful things that result from that, right? And in this case, you know, the emotional trauma of a crumbling marriage. And health status really matters too, right? It just seems kind of incredibly unfair, right? That if you have a health problem, you're more likely to accrue medical debt, regardless of your income status. Finally, medical debt is a social determinant of health, and we at RIP Medical Debt think it's really important to keep talking about it this way because it is becomes a vicious cycle and needs to be taken into account when people walk through the emergency room or hospital doors or seek out care from a physician, where we're really asking questions about people's ability to pay, knowing that we're struggling in a broken healthcare financing system. So as I mentioned before, the drivers of medical debt are pretty clear, that particularly in the South, we'll talk a little bit about Medicaid expansion, and that's why this conversation is so important today as we think about the end of the public health emergency and making sure people are bridging themselves to coverage. But more broadly, it's important to understand that too many people across the country are what we call underinsured. The Commonwealth Fund says somewhere upwards of 40% of people are underinsured. So this really is defined as spending more than 10% of your income on your health insurance, including out-of-pocket costs. So what it means is that you might have insurance, but when you try to use it, you really can't afford it. And as you all know all too well, that Medicaid expansion is a proven solution, right? All the data tells us that states that have expanded Medicaid, people carry less medical debt, full stop. And that having medical debt is disproportionately harming Black and brown households located in the South. But it's also connected to our deep history of inequity around wealth building. And so it's also important to understand that a lot of medical debt, most medical debt, is held by people that have zero or negative net worth, which means they haven't had the opportunity over their lifetime to build savings. And that Black households are more likely to hold medical debt than anyone else, right? So it's clearly a racial justice issue. Now, I just wanted to take a moment to sort of step back and tell you a little bit about how do we get here? So thinking a little bit about how does a bill become medical debt, right? So a lot of people don't always fully understand how people get to this point. So when a bill is sent, a medical bill is sent to an individual, that's when the debt collection process really actually begins. And it's either with a provider or hospital entity, and that they reach out and ask an individual to pay the bill. If the person cannot afford to pay the bill and sort of doesn't answer those calls or responds to those pleas or negotiates a payment plan of some sort, or in most importantly, seek out financial assistance, then that debt and those bills move to a third-party collection agency. And this is how we traditionally think about debt collection. And we'll talk a moment about what the rules of the road are for debt collection. But a third-party collection entity will take this over on behalf of the hospital or provider entity and give it another try to see if they can collect on those bills. And then the final stage is when it moves to a debt buyer. So that means that the bills can no longer really be collected. And so because they can't collect those funds, they will often seek to sell those files in large portfolios, and they sell for pennies on the dollar. So it's also important to understand that medical debt is not treated any differently than other debt, right? There aren't special rules for medical debt, even though medical debt, let's be honest, it's a debt of necessity. It's not a debt of choice. It's the top reason that people, declare bankruptcy, but it's also the top reason that debt collectors contact debtors. And debt collection tactics, the guardrails are up to 7 calls for a single debt line. It also tactics can include garnishing wages, include lawsuits, taking property, and reporting to credit agencies, which would affect your credit. Importantly to note is that when you get a medical service, you get bills not just from the hospital, but also from provider groups. And so you might get multiple bills for one service. And each of those services, say you get 6 bills when you get home from the hospital, then you could get up to 42 calls a day. So for us at RIP Medical Debt, our approach to abolish medical debt for people, we really view as an intervention. And for us, what we use is we use donor raised funds. Many of you might have seen us working with churches in your state or different entities to raise money. And then we buy these large debt portfolios, we abolish the debt, and we send letters of debt relief to individuals to let them know that their debt has been abolished. We do have 2 criteria. It's 400% of poverty or 5% of income. And we actually purchase credit agency data to do data matching to make sure we meet those different criteria. And it's I just want to elevate the benefits of abolishment. While abolishment is certainly not the answer, and we need to get to the root cause, and we're going to talk about that in just a second, it's really important to note, and something we hear over and over again, that abolishing debt is really helpful in improving people's lives in the moment. It's helping them think about their health differently, perhaps going to the doctor again, having a different economic opportunity that they could take, whether it's purchase a house, buy a car, improve their credit. It really helps millions of people weather what is a really broken system. It also, because of who it disproportionately affects, advances racial justice by reducing debt for communities that are unfairly burdened. And it reduces people's stress and anguish, which people carry around. You know, often some debt will go uncollected, but people don't know that it's being uncollected. And so they carry the stress of thinking that they owe money and not answering the phone and not answering the mail. And just sort of is this sort of layer of lingering emotional stress for them that we hope to get rid of. So let's just briefly touch on some policies that could address medical debt. So federal policies that really address medical debt sort of run the gamut, but these are kind of the major pathways as we think about it. You know, as we talked about before, coverage is really important, and affordable coverage at that. And I would even add, as we look at those underinsured numbers, that we need comprehensive coverage to make sure that our insurance is useful. So the Affordable Care Act and Medicaid and associated policies around coverage is really important. Another area of work is hospital financial assistance programs, because thanks to the Affordable Care Act, nonprofit hospitals are required to provide financial assistance to individuals who can't afford care. This is particularly important in states that have not expanded Medicaid. So it's really important to understand these policies. They're each localized, so every hospital has a different financial assistance policy, and that's enforced by the IRS. The No Surprises Act makes sure that people are not getting surprise bills, and even when they've done their homework to check who's in their network. And the Fair Debt Collection Practices Act is really about on the debt collection side and making sure that we've got strong guardrails protecting people from what we call extraordinary collection actions. For RIP medical debt, we sort of really focus on these three areas. The first and foremost is about equitable access to coverage with a strong focus on lowering out-of-pocket costs and expanding Medicaid. And second, making sure that there's clear communication about and enrollment in financial assistance programs for people who are eligible, and banning some of those collection efforts that I talked about. And then another thing that's not on this slide that I would lift up is the importance of monitoring and really understanding medical debt in your state, because the data is really incomplete and difficult to gather. So there are a lot of advocacy opportunities for people that are interested in medical debt and addressing the root causes of medical debt, as well as just abolishing debt to help people in the moment. So at the local level, it's really trying to create relationships and coalition to work with hospital systems to make sure you have the most robust financial assistance policies possible, as well as engaging them in larger conversations, obviously, about expanding Medicaid, as well as adopting sort of, patient-friendly policies around making sure that people are streamlined into programs and support that they need around financial assistance and, honestly, financial coaching before they are sent to debt collection. And then finally, addressing medical debt as a social determinant of health. I will give you one example of some local work that we've done in Cook County, Illinois, where the county uses ARPA funds to purchase medical debt as one means to address the here and now of medical debt while working to expand coverage programs and financial assistance to make sure that all people have access to care. At the state level, obviously, the number one issue is expanding Medicaid, but also there's a number, and it's a very fruitful space where there's a lot of state activity that's really seeking. You can look at New Mexico, Colorado, Maryland, Washington, California, and others that are also looking to add additional guardrails to the federal guardrails around financial assistance. So setting sort of floor eligibility levels so that all people under 200% of poverty, for example, would have access to financial assistance, filling in some of the gaps at the federal level around what we call 501R, which are the regulations for hospital financial assistance. And I would also say monitoring medical debt is a public health issue. This is something that we've seen emerge that we think is really important. The more we think about medical debt in that frame of social determinants of health, and the more we think about it as a public health issue, that it really is the responsibility of those entities as well to monitor and better understand how to intervene around medical debt. And then, of course, at the federal level, there's continued work following the Inflation Reduction Act to make sure that healthcare is affordable and continues to stay that way. And also adding to that and making sure there's a federal option for people in non-expansion states, where those states have decided not to expand Medicaid, as well as thinking more creatively about how we segment out medical debt and think about how it's reported to credit agencies so that people's credit isn't being harmed because they've had a health event. And then finally, of course, streamlining access to financial assistance and creating more incentives for robust charity care. So there are a lot of opportunities and ways to engage in this space, but clearly sort of helping people understand what the repercussions are of not having coverage, which medical debt can be associated with that, is really an important conversation point as people think about unwinding the public health emergency and are at risk of losing their coverage. And so with that, I will turn it back to you, Jenny.
Thank you so much, Eva. We did have some questions in the
Yeah.
chat. Will the presentation be available afterward? And
Yes.
yes, we will be sending it out. And the other question was about the link to the tool. So I put it in the chat, y'all. I hope you're able to see it, but we will make sure to follow up. Eva, I know you have to log off, but whatever other questions we get by the end of the webinar, we'll be sure to send them over to you. And then we'll be doing up some follow-up emails to our participants so they can get those answers. Thank you so much, Eva.
Happy to help. Thanks for having me.
Thank you. We really appreciate Eva taking the time to share this valuable information. And for more information on RIP medical debt and to see if they can help you or your community, please visit ripmedicaldebt.org. I put that in the chat as well. We are now going to hear from Rhonda Hunter, who is a health insurance specialist with the Centers for Medicare and Medicaid Services. She conducts outreach and education activities to the public and health professionals throughout the 8 southeastern states. Currently, Rhonda works with the states of Alabama and Georgia, and Angela Kane, Rhonda's colleague, is also on the line. Angela serves as an outreach specialist who's responsible for outreach, stakeholder engagement, and environmental scanning related to Medicare and Medicaid and the marketplace health insurance to CMS regional partners. We're glad to have you both on the line. Welcome, Rhonda and Angela.
Thank you so much for having us. And I feel like the shadow, it's this time, it's something with Halloween just passing, but I want to thank you all for having me today. And before I go into my presentation, I first want to tell you all that Angela and I work with the Centers for Medicare and Medicaid Services, and we're both outreach specialists. And right now is our busy time, and it's our busy season in the fall. Right now is Medicare open enrollment. So now's the time for everyone on Medicare to compare their health plan options for next year, and that runs through December 7th. It's also open enrollment for the health insurance marketplace. And now people are comparing their marketplace options until January 15th. But we're really encouraging people to enroll by December 15th so that they can have a January 1st effective date. We're also sharing immunization information. We want people with Medicare and Medicaid to know that it covers boosters if you want to get the COVID booster, and it also covers the flu shot if you decide that you want to get one this fall. We also have been sharing fraud prevention messaging. Unfortunately, there are a lot of scams going on, and we want people with Medicare to protect themselves. Please know that Medicare and Social Security do not cold call. We do not call anyone for their Medicare or Social Security information. We already have that information. We do not go door to door in the community. And the Medicare cards do not expire, nor is there a fee for one if you lose it. So please keep these things in mind as you deal with your clients and consumers, just to let them know to be on alert, because unfortunately we are getting more fraud reports. When I talked to Jenny and I saw that you all were talking about the medical debt, another one of our campaigns is No Surprises. And I'm glad that our speaker talked about that, because that's a new law that just went into effect that stops emergency billing for emergency services. It bans surprise billing for out-of-network providers that may be at an in-network facility. And this is commonly with anesthesiologists and radiologists, and also out-of-network air ambulance. So what I'd like to do is share some resources, but just take a moment and just give you a quick let you see this quick video clip about the program.
When patients need medical care, the last thing on their minds should be fear of exorbitant surprise bills. This can happen when patients are unknowingly treated by providers outside of their health plan's network. To fix this problem, Congress passed the bipartisan No Surprises Act. Federal government agencies recently issued the first in a series of regulations implementing the law. Here are 5 things to know about the first regulation implementing the No Surprises Act. First, the regulation bans surprise billing for emergency services. Regardless of whether emergency services are provided in a hospital or independent freestanding emergency department, they must be treated on an in-network basis without requirements for prior authorization. Second, when you receive out-of-network ancillary care at an in-network facility, it must be treated as an in-network service. For example, during a surgery at an in-network hospital, though the anesthesiologist may be out-of-network, you can't get a surprise bill for that service. They must charge you the in-network rate. Third, healthcare providers and facilities must use clear, understandable language to obtain patient approval before providing and billing for out-of-network care. Fourth, the regulations don't prevent patients from receiving care from their preferred providers. A patient may consent to be billed at a higher out-of-network rate for care. Fifth, these changes will take effect on January 1st, 2022. Implementation of the No Surprises Act will help protect Americans from unexpected and financially devastating out-of-pocket expenses. We are working to ensure Americans have peace of mind when receiving necessary medical care.
And I'll be sure to share this as a resource with you all at the end of the session. But the reason I wanted to speak with you today was to talk about preparing for the end of the public health emergency. And as you all know, since the beginning of the public health emergency in March of 2020, as a condition of an enhanced federal match rate, states have not terminated coverage for most individuals enrolled in Medicaid. This condition applies to states receiving the enhanced match rate through the end of the month when the public health emergency ends. Once the public health emergency ends, states will be required to resume normal eligibility and enrollment operations. This will include disenrolling ineligible individuals. Millions of beneficiaries will need to take action to retain their Medicaid or CHIP coverage or transition to other coverage, such as the marketplace. We do not know when the public health emergency will end, but the Secretary of Health and Human Services has committed to a 60-day notice to states prior to the end. And I'm sure you all saw on the news that it was extended on October 13th. And as you all know, each renewal is for a 90-day period. So if there's a 60-day notice, we should get that notice around November 13th. That would be around the 60 days. Otherwise, it may be extended again. Medicaid and CHIP has been a lifeline for millions of people during the pandemic. And as you see, record growth of nearly 89.5 million enrolled in Medicaid and CHIP as of June 2022. This represents an increase of over 18 million individuals, or approximately 26.5%. Much of this increase is due to federal COVID-related legislation. In March 2020, Congress passed the bill, Families First Coronavirus Response Act, that established a continuous enrollment condition. States received extra funding for keeping most individuals enrolled in Medicaid through the end of the public health emergency. It doesn't apply to CHIP, but many states implemented policy for continuous coverage for these individuals. When the public health emergency ends, states will return to normal operations. This process is referred to as unwinding. States will have 12 months to return to normal operations and complete renewals for individuals in Medicaid and CHIP. Approximately 15 million people could lose Medicaid or CHIP coverage. Many will transition to other coverage, such as Marketplace or possibly job-based insurance. States will need to complete eligibility renewals for everyone on Medicaid and CHIP. They will have 12 months for this process. States are preparing, but we know that they have many challenges, including the large volume of renewals that need to be completed, the workforce challenges and staffing shortages by the state Medicaid agencies and the CHIP agencies, the length of time since the enrollee's last renewal, and outdated contact information and mailing addresses. Currently, states are taking action to prepare. They're developing unwinding plans. They're contacting enrollees to make sure they update their contact information. They're launching outreach and communication plans. And we're engaging with community partners, health plans, and the provider community to encourage individuals to update their contact information and provide assistance with the renewals. We do have a toolkit on our Medicaid.gov website for partners and stakeholders. So for those of you who have Medicaid or CHIP clients, this is a one-stop shop to prepare for the unwind, and it's on Medicaid.gov/unwind. And there also is a communications toolkit that I'll show you in a little bit. The consumer website is on Medicaid.gov/renewal. And this is for people with Medicaid and CHIP to learn about the unwinding, get connected to their state agency, and find help and local resources. Right now, we are in phase 1 of our outreach strategy, which is get ready and awareness. So right now, we want individuals to maintain their coverage through renewal or become enrolled for which the coverage that they may be eligible for, whether it's Medicaid, CHIP, or the Marketplace. Phase 2 will begin once the public health emergency ends, and during that time, it will be redetermination and retaining coverage. We do have a toolkit available on the Medicaid Unwind site, and it is a living resource that we continue to update, but it's a very important document that you as partners can use. You can actually localize your information, but it does offer information about what people need to do to renew their coverage. It provides an overview, key messaging, there are digital flyers, drop-in articles, social media, emails, even call center scripts, and it is available in English and Spanish. And this is just a sample of the materials that are available, the social media graphics, drop-in articles, and text messages. We at CMS need your help. As partners, we need help so that people can prepare for the renewal process and become familiar with Medicaid and CHIP and enrollees knowing about these upcoming changes. The 3 messages that we want you to share is for people with Medicaid and CHIP to please update their contact information, make sure that the Medicaid state agency or CHIP program has your current contact information. 2, please check your mail. You may get a letter in the mail, and this will let you know if you need to complete a renewal and see if you still qualify for Medicaid or CHIP. And lastly, if you do get a renewal form in the mail, please complete it and return it so you do not have a lapse in your health coverage. Lastly, we encourage you to join our Health and Human Services and CMS Medicaid CHIP Continuous Enrollment Unwinding Series. It's held the fourth Wednesday of every month for partners. There will not be a call this month due to the holidays, but the next call is December 7th at 12 noon. And I cannot share these slides, but after the call, I will share the Medicaid Unwind helpful contact information. And I do know that some of you on the call are outside of our 8-state region. So I would like to share my CMS contact information, and I'll also share it for my colleagues that are in other states. I'm with the Atlanta Regional Office. And so the states that we serve are Alabama, Georgia, Florida, Kentucky, Mississippi, North Carolina, South Carolina, and Tennessee. And I do serve as the region's lead for the Medicaid Unwind, but we also have state leads in our office if you're interested in any of our other initiatives. For those of you on the call that are in Virginia or West Virginia, Monique Scott is in our Philadelphia regional office, and she serves as the Medicaid Unwind lead. And Ms. Fo Song serves as the state lead for Virginia and West Virginia. And Angela Kane, who's on the line with me today from our Dallas regional office, works with the states of Arkansas and Louisiana. So after the call, I'll be sure and share this information. So you're welcome to reach out to us. We would love to work with you. And if you know of partners that can help us with this unwinding, which we know is eventually coming, and want to help, we would welcome your assistance and help. And I thank you so much for your time. And what I'd like to do now is give Angela an opportunity to speak as well.
Thank you, Rhonda, and thank you for that presentation. I just wanted to add that we actually have what we call local partner connectors that will be helping us. And is that okay to speak to that, Rhonda, about the connectors?
I would just say we're right now, we're just gearing up with the partners. So
okay,
more hands on deck, the more the merrier.
Okay. And these connectors will be helping with the states of Georgia and yeah, Georgia, Florida, Texas, Missouri, and Ohio. But so we do need your support, and we are here to collaborate with you. Thank you. That's all I have to say. Thanks for having me.
Thank you, Angela.
Thank you, Angela. Thank you, Rhonda, both. We have a couple of questions if you are able, Rhonda or Angela. One of the questions we got through the Q&A part of our seminar here is, could panelists talk about the impacts the Georgia pathways will have on current Medicaid recipients?
So that's a very good question. I'll have to take that back and get someone from Medicaid to address that directly.
Okay, wonderful. Thank you for that, Rhonda. Another question here, are we able to drop the communications toolkit link in the chat, or will we be able to share that in the follow-up email?
Yes, I'll share it in the follow-up email. I'll include the resources as well.
Okay, wonderful. If you have any questions, we'll give you some time to ask them in the Q&A section here. And again, we just want to give you all the thanks for your patience as Zoom was having a lot of technical difficulties. So I know that kind of shifted a little bit of our conversation today, and we want to be mindful of trying to end on time. But if you do have a question and would like to get it answered live, we'll also make sure to have that option here available to you all. You are able to ask the question in the Q&A section, or you could put it in the chat and I should be able to see it. But I want to thank our team at the Southern Economic Advancement Project for being a part of this special conversation and getting things set up, we have an update from our communications department. We will be listing this particular recording on our YouTube so that we can share the information from today's conversation to the larger community. A question here, Rhonda and Angela, if you're able, will the state outreach plans be available for the public to see?
And we're waiting to find out if it will be made available. We know that they will share it with CMS, but we don't know if they're going to share it publicly or not.
Okay. Thank you for answering that. I'm trying to see if we have another question coming through. All right, here we go. Let's see. Somebody wrote here, it was a comment, and RIP Medical is not on here to address that, but I will put the comment here. RIP Medical paid my debt in 2018, but I recently got a flag on my credit report. So we'll be able to share that with Eva through email so that maybe they can help address why that could have happened, but we'll make sure to look out for that. Thank you so much. All right, y'all. Well, we really appreciate Eva and Rhonda and Angela and Sarah Beth giving us a great overview of what we've already done. We at SEAP are always trying to make sure that we're providing you all with as much information on different policy measures as they come about. And we want to make sure that you all have all the tools that you need. We will be responding back with an email to all those who registered with us and putting some of these clips on our social media so you are able to share. We want to make sure that we're giving you as much as you can have in your armor to help your community members as well. If you want more information, please visit us at theseap.org and follow us on social media at SEAP News. Please make sure that if there is anything that we can help you with, you let us know. After today's webinar, you will be immediately sent a survey. If you can respond to that survey, it'll stay on your screen. Let us know what else you want us to talk about. We really appreciate having this opportunity to share this important series on diving into debt. As we talked about student loan debt and we talked about medical debt, we want to make sure that we're providing you all with everything that you need. So thank you all so much for your time, your patience, and certainly your support in trying to learn more about these important topics and sharing them out to your community members. My name again is Jenny, and it was really a great moment to spend time with you all to talk about this important topic. I will go ahead and end the webinar, and we will see you all next time. Thank you all
so much.
Bye-bye, everyone.